All right. I believe that we are on, and I see we have a few attendees joining. So good afternoon. My name's Terry Tusnick. Oops, I'm going to start by recording this though. Oh, there we go. It is. And I'm a board member of the HIMSS Arizona chapter, and I appreciate everyone joining us today. Today's webinar is produced in conjunction with Arizona Nursing Informatics Association, so thank you for that. We have an engaging lineup of healthcare informaticists, I need to speak, for our fireside chat on insights and lessons learned from healthcare informatics leaders in today's fast-paced evolutionary healthcare environment. So I want to start with our slides just to thank our 2024 annual sponsors of Arizona HIMSS chapter. Thank you so much. I also want to do a little housekeeping. Remember, you've been muted upon entry, and we ask that you remain muted during the presentation. Feel free to type any questions in the chat box, and I will address those either during the presentation or at the end. We are recording this session, and it will be available on our chapter website shortly. Again, thank you to our sponsors, and I would like to just move my deck forward a little bit here. Just to share the vision and mission of Arizona HIMSS chapter with you. So thank you for that. I also want everyone to know that we have a few upcoming events. We have our holiday happy hour that will be shared with Phoenix Children's Hospital, where we will be raising funds for their annual toy donation. It should be sometime the first week of December, so we'll have some information coming out shortly for you. And in April 2025, we'll be holding our annual health summit for everyone. We do offer CEs for today's session, so just wanted to go through the learning objectives, and you'll need to go out to the HIMSS website to get those CEs, so please reach out if you have any questions or comments about that. So I'm going to now take it off of the slideshow, and we're going to start our fireside chat. Let me just stop the share there. So thank you, everyone. And I would like for our group of esteemed panelists to introduce themselves. And Candace, I'd like to start with you.
Yeah, thank you. My name is Candace Larson. I am the Chief Nursing Informatics Officer here at Honor Health.
Okay, excellent. Dr. Norquist?
Yeah, I'm Craig Norquist. I actually work side by side with Candace as the CMIO. So as a physician, we're a dyad at Honor Health.
Dr. Anderson?
Hey guys, I'm Matt Anderson. I work with Craig and Candace quite a bit. I'm the ambulatory CMIO, so I cover the entire outpatient world here at Honor Health with a focus on virtual care.
Michael?
Hey guys, so glad to be here and chatting amongst esteemed colleagues. I'm Mike Jones. I am the Region Director for Informatics for Common Spirit Health. We know our brand within Arizona as Dignity Health in that space. And I don't want to steal the thunder, but I have a great dyad partner when we set up this meeting, and that's Dr. Don Kane. So we, again, work hand in hand to meet needs of our clinicians within Common Spirit. And side note, I'm the president for Arizona chapter ANIA, and glad to have Candace on that board with me as the treasurer.
Thank you, Mike.
Dr. Kane, anything you want to add?
Thanks to Michael for the pitch in. So it's like a well rehearsed radio program. So I gave him the lead in, but no, partner with Michael, also with Dignity Health, also known as Common Spirit Health outside of the Arizona market.
Okay, awesome. Well, and again, at any time, please feel free to, if you have some comments or questions for our panel, please put them in the chat. I want to start with a question, which is for anyone who would like to jump in and start. How do you bring your providers and clinicians joy in doing their job? You know, since that's part of what we do as healthcare informaticists.
I can start, or I saw you come off, Dr. Anderson. Feel free. Okay. So part of when we think about joy in clinical practice, as a nurse, we come to the table because our joy space is to deliver care to our patients, create those relationships. We are servant professionals at heart, and that is where our joy stems from. How do we make those connections with our patients, bring healing to them, and disease prevention and promotion to them? Ideally, we know that technology is a conduit in how we show the care we are delivering, but should not be a barrier. And we know that we have oftentimes now made technology a barrier to practice. And our space that we're focusing on now is, how do we lessen that? How do we create technology that is a companion to care with our clinicians so that they can focus in on why they come to work every day, and that is to take care of our patients.
Anybody else like to add to that? That was a great answer, Mike.
Yeah, I'll jump in. I think sometimes when we bring joy, it's when we're removing some of the barriers that block just that delivery of care. And sometimes it's when they don't even know that we've done something. It's when we've made it so smooth or so easy that they don't even know what happened. I think also just sometimes making people feel excited about some of this technology. It's sometimes seen as a burden, but one of the programs a pilot program we're working on is using artificial intelligence to help generate a draft reply back to patients through the EMR. And so we've been kind of practicing with that, working on our AI prompts with the physicians and the pilot, and they kind of like it. They give me a lot of good feedback, more than I ever expected, because they really want it to work. And they've told us that it's the first pilot project with technology that they've been involved in where it really felt like it actually improved every day. And so it's one of those things where you can see them get excited about it. You can see them take some ownership of it. And then I think that leads to the joy of just providing good care.
Yeah, and I think, I mean, oh, sorry, Candace,
Yeah.
but to echo whatever other people have said, I think sometimes that is the maybe not frustrating part of our job, but we operate in the background so often, right? It's refreshing when you don't get a phone call sometimes, right? Because things are just working. And sometimes that gets really highlighted when something doesn't go as well. We've had so many successful upgrades of our EHR. They went smooth. Nobody even noticed that anything changed, or they noticed that it's improved. But one time when it didn't work so good, we got lots of phone calls that, hey, how come you didn't let us know that you're doing this? You should let us know every time and about every detail. It's like, well, we've been doing it every quarter for the last 5 years. And we've been successful at that. So we strive to let them in on everything. But then sometimes it just happens naturally. And sometimes a good day is a quiet day, and it lets you kind of do some of the other stuff. Mm-hmm. But really then also, like was said, it's just making sure that somebody is able to give the kind of care that you as a person would like to get from that person. You don't want to go into an exam room and have the doctor, with their back to you because they're typing on a computer, or have a computer between you. You want to be a partner, maybe a triad with the EHR being part of that visit and sitting there alongside that provider. And so whatever we can do to try to help facilitate that, I think sometimes is just little baby steps towards improving everything that we can do.
Yeah, and I would say from a nursing perspective in my world that it's that partnership and collaboration and involvement, transparency, because when you do have your clinicians involved in the solutioning or along with you in the process, there's a trust factor, and they give excellent feedback. So I think taking that and making it a partnership in that solution. The end goal is a more productive and engaged, solution that we can work to continue to optimize versus not bringing them along the way. So that's where I've seen that value, that partnership with our clinicians' involvement in some of that decision making to make it successful, and feel like that there is value, and and just seeing the joy in what has been produced. So I would say that's what brings me joy too in my job.
Yeah, and I think I'll wrap up. And so as the grayest member of the panelist group here, I've been doing this for a long time. But so I think traditionally I've been just the boring stuff of optimizations and improvements, which are not, those aren't bringing joy to anybody. But that we actually recognize that there is joy to be provided to our clinicians and assessing it and measuring it. So the AMA has the program on a joy medicine recognition, which is I was reading up on it to prepare, and it's focused on providers only because it's the AMA, so consider the source. So obviously we have other clinicians that need to have joy as well, but also assessing it and looking at things like the class survey, where you're actually measuring what works and how do your staff members interact. So that's something that we've had the ability to do. It's actually just measuring and looking for those things that where areas where we can improve. So that's probably where I would look for in is measuring it, so you know if you're actually doing what you're intending to do.
Great answers all. One of the most profound questions somebody asked me recently was, what brings me joy personally? And I had to think a minute about that. So I'm going to toss that question out at you, as you've talked about bringing joy to your providers and clinicians. So give me a little insight into each of you. What brings you joy? Oh,
We got you. We'll let one of the doctors, we'll let one of the docs kick us off here.
yeah.
I'll be last. I'll do reverse snake like a mock draft here. So I think that just personally, and if you ask on a personal basis, I'm a problem solver. So I changed my clinical focus from solving problems for patients and pediatrics, which is my clinical specialty, but solving problems for our end users. It's still, I just had to shift the way that I do that, and doing that with the team. That's what gives me joy, is to problem solve for someone. Someone comes with something that they've been banging their head against the wall and they just can't figure it out, and using those tools, a nice rubric of people, process, and platform, which one of those areas is it and where can we help? So all right, I'll pass it on.
Yeah, no, and definitely that is certainly one thing that does kind of drive us to continue to do this day after day, because when you see that level of satisfaction that somebody has when you're able to finally crack that nut of frustration of something that they've been dealing with. Sometimes that means you have to wait for the technology to catch up to where you are. Sometimes there's been the technology all along. Sometimes it's just a matter of, bringing people together, bringing in a fresh set of eyes, and that definitely is helpful. I actually also, take a tremendous amount of joy when we see that we're actually improving our access to care, the delivery of care, and recognizing some of those things that maybe we had ignored in the past, like the social determinants of health.
Mhm.
I'll admit, at one point I was kind of a skeptic of that, but then as I dug into it, as we started to actually collect that data, it's like, oh, wow, we can do so much better if we know these things about people. And then just getting that kind of inertia and having everybody recognize that, and then starting to deliver a kind of more personalized level of care to somebody where they are and when they need it. I think that's really something that's satisfying.
And I'll jump in next. I would say that breaking down barriers and thinking outside the box and giving the opportunity to be innovative, leveraging our clinicians and trying new solutions, that gives me excitement and joy, because that just opens up the door for other possibilities.
Well, sometimes joy is outside of work. And, I think that's, for me, I do, what really brings me joy is being outside of work with my family, doing those sort of things. And I figure that everyone kind of feels that way too. So when I can help them be at home, when I can help them disconnect from work, get their work done faster, more efficiently, then I like that, because I know that that's what I want to do. I mean, work is great, but I like being at home with my family, and so I like doing the things that make me happy, and I want to make sure everybody else has that opportunity too.
Mike, anything to add?
I will bring it home. I think joy can have multiple dimensions. And we pointed that out both from a work and personal perspective. The ultimate woven thread through my joy is service. And so that is echoing what we just said amongst all of the professionals on the on the Fireside right now. Love seeing that our end users give feedback where we have improved their world in some form or fashion. We're able to give time back so they can see the patients. We're able to bring technology in to help them make better decisions about patient care. These are all the things that can bring us joy. In a personal perspective, I still want to make sure that I look at how the legacy of Mike Jones can be viewed when I pass on, and that is making sure that we are creating the future leaders of healthcare and the future informaticists that are going to continue the evolution of the bridge in care delivery and technology. So I think I'm going to end with the woven thread is, how do I be best of service within my life, personally and professionally?
Great answers, you all. Okay, next question. AI is everywhere. There are AI vendors. It's pervasive in everything that we do. So how is AI being used or being planned to be used in your organization? And what are your thoughts on how its usage? Who'd like to dive into that one?
Let's have Matt go first because he's
Yeah.
actually doing it, which is
Yeah,
good.
I kind of mentioned that earlier. I think one of the earliest things that we've done is this generative draft replies. It's really taking a look at how to eliminate that inertia of starting a message back to your patient. We get tons of patient messages across all specialties, and sometimes just seeing that in your in basket, just seeing the number that you have can be a bit daunting. And so with a generative draft reply, it's using large language models and that natural language understanding to create what it predicts what it thinks could be the best reply back to that patient, kind of using the context and using things you've said in the past. And so we have that working with 14 clinicians right now and their staff. And so we've expanded it to their staff as well, because a lot of messages go to a pool and they works with the staff as well. So what we have found is that we are making both the clinician staff, their medical assistant staff, and themselves more efficient. So they are spending less time reviewing patient messages and drafting patient messages. So the most recent data I looked at this morning, we're saving each person when they use the generative draft reply, they're saving about 57 to 58 seconds, which is a small number, but you start thinking about the hundreds of messages we get a week, the thousands of patients messages we get a month. We're getting really good feedback and being able to augment our AI engineering prompts. So it's been really fantastic from that standpoint. So again, it's not making medical decisions. You're not giving any advice. You're not giving anything. It's just being able to prompt that for the physician and say, hey, in the past, when someone had said, I have X, Y, or Z, you've said this, why don't we say something similar? And it can still be edited by the physician themselves. So I think that's been very exciting, and we hope to continue to expand that and provide everyone in our organization with that ability to save a little bit of time. We're also looking at ambient AI from a voice technology. We've used a lot of different types of speech to text, but those have not had the same effect for our clinicians that I think we were looking for. So we've tried a couple of different versions. We're going to be starting with ambient AI here pretty soon, which can, again, take what is said inside the exam room, create a note immediately, and really take that burden off of clinicians. So I think those are probably the two biggest areas where we see AI as a tool, as a way to support our clinicians, not as a replacement, not to do diagnostics. I mean, I truly think that's probably, the more I look at AI, the more I realize that that's a little bit farther off than I think people would like to think. So that's what we're doing right now is really helping out documentation with physicians.
So a place where we're going as soon as we can get to another upgrade, and as some of you guys know, we've recently expanded a little bit more rapid than we were anticipating. So things have slowed or got put on a back burner, but The next level or the next implementation of AI that we're really looking forward to is using a similar large language model, but where it's only looking at that patient's chart and information, and then condensing it into a brief synopsis of what's happened to this patient since the last time you saw them, both from an ambulatory perspective. So Dr. Anderson, if he was working in the clinic and hasn't seen a patient for 6 months, it's going to trend all their labs, the meds that have been refilled, any other visits to the ER, and have the high points so that you can get in there and you know. So you don't, I mean, doctors are already doing this, but it takes a bit of time to sift through, okay, what did I see him last for? What else has happened? Where are their labs? And things like that are getting a little bit better. But this is putting it in just a paragraph that makes it make the most sense. For the emergency department as well, it'll pull out the high points of that patient that are potentially related to why they're seen. And then, as Candace will probably mention for nursing, at the end of a shift, it'll do a shift summary of what's happened with that patient. So there's a lot of really interesting potential, and it's kind of exciting. And that, maybe back to the previous question, that's going to bring us joy when we're putting something in front of someone, just seeing them go like, oh my God, where has this been all my life? Because this is going to just make it so much easier for them to give care at the bedside, rather than being, you know, the person who's in the computer looking at stuff.
So another project that Dr. Norquist and I worked pretty closely on the inpatient side, in particular to support nursing. Through COVID, it was very challenging with a lot of our newer nurses. So we had the opportunity to implement the deterioration index predictive model. It's a scoring tool that you know, proactively can nudge the nurse that we have a, you know, a change in status. Again, to Dr. Anderson's point, everybody else, it's not telling you what to do, but it's really that tap on the shoulder to signal the nurse, hey, you know, you might need to go in and assess this patient a little bit more often, go check in with the patient, what's going on. But giving you the opportunity to, you know, make that phone call preemptively. You know, I don't think things are going well, things like that. But, you know, overall arching goal is to reduce the, you know, amount of unintended transfers to our critical care unit. So, you know, again, kind of going back to that transparency and partnership with our nursing, they had to work with us very closely. They had to trust the process and the scoring. We got feedback. We, you know, massaged it to the point where, okay, I think we all feel good about this. So it wasn't, you know, pushed on them, but we really had to, you know, listen and hear and understand some of those nuances and reasons why that score didn't align well. And so we were able to make some adjustments. So we got in a good spot, as well as piloting. I cannot, you know, underestimate the value of piloting. It was very instrumental, and then scaling it to the facility, and then having that comfort level where we could scale across the entire network. So that's one example of AI that we've most recently leveraged in the nursing space. And again, looking forward to end of shift summaries and some other types of solutions as we get, you know, embark into the virtual care and some of those opportunities to leverage AI. And again, to complement and augment care, not to, you know, dictate and tell you what to do. So
as before we move over to Common Spirit, do any of you have any concerns about the usage of AI? Had to ask that question.
Well, I think we always have to be concerned and go into it with our eyes wide open. And I think that's kind of where we're all struggling. We really need to have you know, a governance process in place. So, you know, looking at it from the technology lens, but as well as a clinician lens, and even from an informatics lens, you know, we're kind of in between, or the eyes and ears. So I think, you know, getting the right stakeholders involved in the governance so that, you know, we can partner with our clinicians as we move forward. We need to have that transparency and trust factor, you know, in order to use the technology.
Yeah, and so one thing we're trying to do in terms of governance is we're trying to stratify the risk that could be associated with an AI. So an AI prompt that doesn't necessarily try to convince the caregiver to change their care is at a much lower risk than one that says, you need to do this, right? So for instance, sepsis prompting to say, you know, we suspect that your patient is getting sicker and they might be septic. You should look at the patient. That's much lower risk than, your patient is presumably septic and we're recommending that you order a lactic acid, 30 cc per kilo bolus, call all bells and whistles and all that stuff. That's a little bit higher risk because you could potentially do some harm to that patient. And when that happens, that doesn't mean we're not going to use it. It just means it needs to have a different level of concern brought to that provider so that they're aware that this is how we came to that conclusion, right? Their blood pressure has dropped, their heart rate's gone up, their temperature has gone up, there's a known infection. You need to present all of those things to the provider so that they're aware of why the decision is being made. It's starting to get closer to that kind of explainable AI, but it still is lacking, but it's the best that you could do. So we've had a lot of conversations with our providers who are hesitant to move forward in risk stratifying because they don't want to not use the tools. But then when we talk about mitigating risk, then it brings some comfort. It's like, okay, because ultimately it's on us as the doctors and the nurses who are caring for that patient, regardless if AI tells us this patient's sick, this patient's not sick, go see this one, not that one. And so it's on us. So we need to make sure that they're armed with as much information as possible, and at the same time not overwhelming them with information.
Great. Dr. Anderson, anything to add?
No, I mean, I think what we do is hard. Everyone in healthcare has a hard job. It is very difficult, whether you are checking someone in, your OR, your physician, nurse, whatever. It's really difficult. And just because we have a tool and the tool can do one thing, you can do one thing in healthcare. That's it. And so I really do think that we can use these tools, but the judgment of those tools becomes so much more important. You think about the difference between when we used to take out people's appendix because we thought they had appendicitis versus, now we have a CT scan. There's still judgment there. There's still judgment that's involved. And I think over time, the role of judgment will become so much more important in an AI world versus, without it.
Mike, Dr. Kane, now we're going to come back to AI being used in your organization and your thoughts and concerns on its use.
Yeah, I want to let Don weigh in because I have some summary thoughts as I've been listening.
Oh, thanks, Michael. So yeah, I think as my colleagues have pointed out, we're looking at probably two big buckets. So, what vendor supplied information, what vendor supplied content, whether that be through your native EMR or something like, from an ambient listening perspective. And then governance is obviously going to get to that. So thank you, Candace, for mentioning that, because we want to put some guardrails around what people are doing. When we're looking at the innovative side, the other big bucket of that is innovation. When we have end users are trying to solve a problem and looking to use this technology. As far as concerns, I would say my concern is and Dr. Norquist put there, it's still up to the judgment of the provider, but we're doing a summary of care. So I provide you a summary that's all queued up for a discharge summary. Well, we've seen the slop and paste that used to happen with Dragon, where no one would actually proofread anything, and just amazing gibberish would get into the chart. And no fault, they're busy people and they're trying to get home, like Dr. Anderson pointed out. But we want to make sure that that behavior is set, that you are responsible for this. Just because the computer says, hey, here's a discharge summary, I do have some concern that they will just click through and looks good to me and they're moving on. So that's the behavioral and professional ethical thing that I think we need to stress, and in collaboration with our other leaders too. It just can't come from informatics. So Michael.
No, great points from everyone. As we've been discussing AI, we have talked about examples of that is what's in the now. I do believe that the AI of the future is what we have not even thought about today and what we can't even comprehend at the moment. So knowing that, and this is my, in my humble opinion, personal belief, in knowing that we have to look at human behavior and human response. And we've seen this already in action, specifically within nursing, where there are fear-driven responses, contesting the use of AI, going to steal jobs away. We saw this in most recently, primarily through represented nurses. However, there are many nurses that share that same thought in the same breath, there's nurses in practice that see this potential value. So what I would say and what I have been sharing in my journey in interacting with other nurse leaders across the US is it is our time to be and this is for physicians too, by the way. It is our time to be present upfront. We talked about governance within the health systems and the framework of our risk mitigation, but this starts way sooner. This starts with our technology partners that are engaging and investing and creating this AI. There needs to be clear demonstrated evidence that clinicians were a part of this conversation before it even gets into the hands of a health system. So when we are looking at AI, we really are just starting to chip away at what this may bring. So the call to action for all of us is early engagement, presence, and ensuring that what we're bringing to the table is going to bring the value that we anticipate.
Oh, great answer, Mike. Great answer. Okay. Next question. Want to talk a little bit about virtual nursing and virtual technologies and how are those being used in your organization today? And I'll still throw a little bit more and thoughts about that, good or bad.
So in our organization, yes, we are kind of, I'd say, getting our toe wet and acclimated to what is virtual nursing. We know that, through COVID, we struggled with, the workforce, the young workforce, and saw an opportunity to leverage this type of technology. Right now in our organization, we have it outsourced. We have it, I would say, in a pilot mode on 3 floors in one facility. It has been a journey. Again, kind of talking about vendors and those definite opportunities, but it allowed us to establish, what that looks like, how we can perhaps scale in the future. Also having those conversations, is this the road that we want to go in internally supporting it as well? So we are having those conversations and looking at those opportunities. We have a workforce that's also aging. There's opportunities to be in a different type of role, mentoring roles, or flexing, perhaps, 1-2 shifts virtual, and, the other is bedside. So we do have those interests, today that are being vocalized. So I think we need to hear our clinicians. It has been a benefit. There has been, staff retention opportunities, recruitment opportunities, as well as patient engagement scores rising. We've had some very phenomenal results. But, like working with any vendors, we have our challenges and opportunities, so we recognize those. And so when we go to our next iteration, we keep those in mind and we will refine those workflows and, make them work for our organization, moving forward to be successful. So we, see other use cases. We're exploring those. We've just recently initiated a virtual care committee. So, there's other use cases, EICU, there's opportunities in transitional care, ambulatory. So we're just, how do we model that and bring that together with the solutions that we have so that, we can work together and, be on the same page?
Agree. Virtual care is not necessarily brand new to healthcare. Some of the work that we're discussing now, and Candace did a great overview where we're talking about virtually integrated care with a nursing focus, it is reasonably new. But we can step back and look at virtual observation, or what some coin virtual sitters. That has been around for a while in that space. Centralized and virtual monitoring for cardiac services. So this concept of centralizing services or technology is not new. Now, what's new, and I'm getting ready to date myself, so I believe we've all heard the model of primary nursing or primary care nursing, and we would have a registered nurse, a CNA, an LPN, a tech, name the team. We are really redeveloping that that primary nursing model here. It's just now we have a virtually integrated care nurse as a part of that team member. And it is looking at how do we create that practice that allows great nursing care in a virtual setting. And that can mean, and not limited to, helping the nurse do assessment. We were looking and still determining how do we help with wound management and wound assessment, education, discharge planning with the patient. These are things that don't necessarily require an in-person licensed practitioner to manage that conversation with the patient and family. So when we're looking at these new models, it really is looking at how do we augment the staffing with the right people at the right time delivering the right care. And that is not a new concept. We're just now bringing new technology and new clinicians in with it. And I'll pause because I know Don may have some words or the other doctors, but again, virtual ICU is decades old. Johns Hopkins were early piloters of virtual ICUs. So again, we're just bringing it along and evolving the practice with the technology.
Yeah, I just want to interject, Mike, but yeah, kind of what's old is new again, but with another flavor.
Yeah.
Yeah, because I date back to as well with that team nursing concept, and that's kind of one of the challenges that we've seen is that primary nurse kind of giving up some of the delegation of some of those activities and that trust factor with that virtual nurse. So that's been very interesting to see, and kind of evolve and shape the nurse, the primary nurse's role as well too. So that's been good to see, but again, recognizing that there are some delegation challenges. And to your point, there's definitely opportunity with ancillary roles in virtual consults and things like that, we certainly would like to embark on and bring those partners along the way.
Yep. As our technology improves, we will see these services continue to grow and strengthen so that we can bring better care to our patients at the bedside. Dr. Kane, anything to add with our virtual service?
No, I defer to our two nursing leaders who are experts here for nursing. I think one, just because I go to a lot of meetings, I hear a lot of information. One of the nice benefits around virtual nursing was an improvement in patient experience. So we all know our patients filling out surveys, and when that nurse is able to beam in and make that touch point, because the bedside nurse, he or she is busy caring for, pick your staffing ratio, that was a nice benefit to have. And it also, when it was offered locally, there was a rush of nurses who were further along in their career who had never thought of be able to have a remote job. They probably have children who are remote workers, like I'm a remote worker. So that opportunity, so they had to throttle back the number of applicants. They didn't want to lose their core veteran bedside staff because, oh, I can work remotely now. And so that was a nice unintended consequence there. So nothing further there, Michael. Thanks.
What I will end with is as we create this journey of virtually integrated care, it is also a new mindset for the clinicians, because nurses that have been practicing for a while, I'm going to say that as opposed to old nurses like me, that have been practicing for a while, we're used to that in-person engagement. That is part of what brings us joy, is the physical touch, us being able to heal through that connection. And that looks very different when we are a camera and a picture. And so that still does take a shift on, we're still bringing value. We are still caring for the patient. It does look different.
That's a great point, Mike. And I think, when you talk about things that bring clinicians joy, as a nurse myself, that was a hard transition from the bedside to being in the world of technology and informatics. So yeah, very, very different. Dr. Anderson, Dr. Norquist, anything to add on this one?
Yeah, I could probably talk for the next hour on virtual care. It's kind of one of my passions, but I will make a point about the change in technology. This is not a new fact either. You think back to, and I'm going to nerd out, but on stethoscopes, right? There was a point in time where like using a stethoscope was too much technology because you really needed to get your ear right up to the patient's chest, right? Like that was the standard of care. And it was only Linnaeus and creating a stethoscope that changed that. And it didn't take off right away. So, I mean, I think there are so many examples of this. I think this is just one more step. When we talk about in our at Honor Health, we have the clinical innovation department, and so we have some people in that just focus on virtual care. We really try to take a look at how to push the envelope and really think about this is not virtual care. This is care, and one of the tools that we use is video and asynchronous care. And so being able to deliver the appropriate care in any manner. So we still do some in-person work, but we really focus on video and asynchronous care. Those are ways that we can meet the patient where they are. Kind of like speaking of everything old is new again, right? We used to, as clinicians, we would ride our horse out to our patients, farm and to their house, and we would meet them where they were. That changed. I think you're seeing the ability of technology to make that a little bit more personal. So, it may not be able to touch them, but I get to see their house, right? I get to ask them about the things that are in their background. There are things that patients can share, and you can involve family members in a different way in their home than you could you just waiting to see one patient in your office. So I do think that mindset shift that Mike mentioned is, to deliver care and to use every tool available, whether it's in person, virtual, however you use it, it's just delivering care.
Dr. Norquist, anything to add?
Yeah, no, I think everybody's kind of given some really good points. And I think, maybe just to add to it, we can start to think out of the box. So after a patient's been in an acute care facility, we need to get them to see their primary doctor pretty quickly. Otherwise, they're at risk of coming back into the hospital. What better opportunity to use virtual care if we can't get them to see their primary doc in 7 days? Right now we have nurses calling them, but what's the harm in having a doctor kind of check in and looking at the chart, reading what's happened, reading what the concerns are, asking them some additional questions, or even having our pharmacist call, make sure that medication reconciliation was done appropriately, that they were able to get the medications, that they weren't denied through prior auth. So many different things that we could do that in the past has meant, okay, come in and see me, so that we could sit down and take care of this. It's like, that just isn't the way we need to think anymore. So we have a lot of potential.
Yeah, that's such a great point, because we also have the opportunity to leverage APPs in these more advanced spaces where we know that we have physician shortages. We certainly have the opportunity with APPs to leverage technology related care delivery, and especially in that important post-discharge acute space where there is the potential for a readmission. So you're on point.
Okay, and we're coming down to our final question. So I will ask attendees if you have any additional questions in our last 17 minutes. Please put them in the chat so that I can ask the panel. But my final question, which is a pretty meaty one, I think we all agreed upon, is how are you doing with change management and prioritization in this extremely crazy, ever-changing healthcare world? Who would like
I'll
to
jump in. Yeah, I'll start. I think it comes back to, I'm in emergency medicine and I've been going to emergency medicine conferences for years. But one of the things that's stuck with me over 20 some years is, 3 rules. Always do what's right for the patient. Second, do what's right for the person giving care to the patient. And then the third rule is not to confuse rule 1 with number 2. A lot of our providers would like us to do all kinds of things to make their life easier, but it actually comes at the expense of a patient being inconvenienced. And I think we need to make sure we remind ourselves that we're in this job, not necessarily to make our providers, our nurses, our doctors happy, although that is a major part of what we do. We need to make sure that our patients are getting the care that they need and they're getting the outcomes that they expect. So those have to be kind of the priorities when somebody's asking, hey, we need to do this. It's like, well, does it Does it help us deliver better care to patients? If it does, then you go to the next step. Is it also then going to come, are we going to require, significant change to our current workflows that's going to inconvenience the providers? And is there any other way we could do it? If it then, meets those criteria, that it moves on. If it doesn't satisfy the first one, then it could be a lower priority, or sometimes it just gets outright denied because it just, we don't have the bandwidth to be answering every change request if it isn't going to improve the care that we're delivering. So you need to have some sort of a rubric that does something like that. But then there's going to be a lot of things that fall into those. Yes, it meets those two criteria, and you have to try to prioritize which ones then are able to be done with the existing resources that you have, which are going to require additional resources. So there's a lot that goes into it. And I think sometimes we're naive just thinking, hey, just put in an idea and they'll take care of it. But then when you start to get in this job, you're like, oh yeah, there's a lot of people who have to get mobilized to make stuff happen. So
there's a name for that, Dr. Norquist. It's called poof syndrome. Poof, make it happen.
Yeah, exactly. Right. It just goes away. But yeah, and then sometimes too, we forget that other people don't know that. And so just giving them some feedback. It's like, hey, I know you put that request in a month ago. We just can't get to it, and we're looking at it again, but we're not going to be able to do it. Or we can't do that because it conflicts with a regulatory requirement over here. And if we don't do that, then people, have the poof syndrome, or they just, think I'm going to stop requesting anything because nothing ever happens here. And you need to make sure that you're not doing that. So I don't know that I actually answered your question so much, as just went off on a tangent, but
Well, I'll take off what Dr. Norquist said. About 4 years ago, we really didn't have a good process for accommodating requests. And so we have now established that. So it's better than what we had. Literally things were going into a black hole, smoldering fires, and, it's a lot of, being reactive. And that has gotten better. So I think having a more organized governance process fashion, it's not perfect, but at least we have our operational partners owning those requests, and we're partnered with IT, informatics, data analytics to review those ideas. So it's a collaborative effort, and we also reach across the aisle to these different groups to get input and feedback. So yes, feels like it's a bureaucratic wheel and it moves slow, but in my mind, nothing's worse than forging ahead on a solution or a change, and then it comes back to backfire, and then we have to do damage control or reset and restart again. So I think being thoughtful, but sometimes we get hung up within the whole process, and we'll continue to refine that and work through that. But again, some structure, an organized structure is better than not having any. So that has, I think, been valuable. And then also to balance some of those strategic projects too. We got this bucket here where we're turning the small, medium stuff, but then how do we tackle some of the strategic, service line department initiatives that also need to take priority as well too. So it's really a balancing act at the end of the day that, I think we juggle on a daily basis.
Dr. Kane, any thoughts from you?
Well, thanks. Dr. Norquist said the three things in the ED. I thought it'd be IVO2 and monitor, because that's what I was drilled at as a medical student. I still remember to this day. But no, I think that somebody broke the word governance. I think it was you, Candace, mentioned the word governance, and it's the sausage making of what we do to make things work. And it's not pretty. It's you tell an end user, a physician, a nurse, or a pharmacist brings you a problem, they really don't want to hear about governance. But it's because we have to have that. It can't just be random. So it becomes a resource issue too. You have a limited amount of resources to do certain amount of things. So setting what your priority system would be, and make sure it does include those optimizations, because you want to do the things that are patient safety and regulatory and revenue generating. But we also want to make sure that we provide that joy that we talked about earlier. So yeah, governance, it's a necessary, I won't say evil, but it's necessary. So that's all I had. Thanks.
I would add AccuCheck as well to your.
Oh, there you go. See,
I thought it was a CT scan. I thought
Yeah,
I thought you
right.
had to get the
Well, no,
CT
that
scan
comes
first
later.
before any of
Yeah,
that.
no. Yeah.
I
But
would
I would
say.
oh, go ahead.
Go ahead.
No, I was just going to add the one thing, so sometimes if you leave the prioritization up to someone else, they'll figure out what they need to do to make it a priority. So patient safety becomes the concern for everything when in fact it might not be. So you need to have some oversight on those kind of things and maybe check some people every now and then. It's like, hey, you mentioned this was a patient safety issue. Could you explain that more to me? And when they can't, then you can kind of deprioritize accordingly. Sorry about that, man.
Oh no, I was just gonna say, I mean, the truth is most people don't have bad ideas that would hurt the system or hurt patients, right? And so it's sort of that cliche in medicine, there's a right answer and there's a more right answer. And sometimes just explaining to that if we can't do something, it's not because it's a bad idea. It's not because it's a failure or it's something bad. It's good. It's just not as good as where else we need to focus. And I think the bigger your organization, the more you have to have those conversations. The more you have to say, yes, that's a great idea. It will help 2 people. We've got 15,000 to worry about. And so we need to be able to focus. And so I think that reassurance that yes, it's a good idea. Yes, if we could, we would do it. But we do have to focus on other things. So that helps a little bit when it comes to change management.
Mike, anything else to add?
Yeah, a couple things. I think one, I echo certainly what the other panelists have shared. And one of them is what I call the bumper guards, also known as governance, right? Do we have a set of standards or rules of the road in which we practice within so that we can still have momentum moving forward? What I would also say when we're looking at change in today's healthcare environment, pulling it back a bit globally, it is always around patient-centered care. Sometimes folks get slightly separated from that notion, but every day, whether we are directly touching a patient or not, we come to work because we are going to take care of a patient today. And so one, our business is designed around patient reach, patient care delivery, and across the continuum as our organization sets that. And number 2 is love does not keep the lights on. That's my grandmother saying. And we have to be compensated for services that are delivered. And I don't know if anyone knows, I'll pause for a second, but what's the, because they can put it in chat, right? Terry, is there a chat feature in here? Okay. So what is the average margin health systems attempt to achieve each year? Average. Some are better, some have higher, depends on payer mix. I'll pause for a quick second.
Please feel free to put that in the chat.
Because this is important, right? We often don't talk about money, but it is a component of how we deliver care and service.
Oh, come on, somebody be
Oh,
brave.
come on. Take a guess. Guess. 10. Okay, here 10.
Anyone else?
One more. Let's give one more.
5. I'm just gonna.
Okay, so 5. So the average of what we strive for, depending again, payer mix, size, etc., is a 3% margin, right? We want to operate achieving a 3% margin. Now let's give an example. Terry, you're in consulting. I came from consulting way back in the day. We wrote contracts to a 30% margin. And so when I share that, we do not have much wiggle room in decision making when we are looking at value to dollar. And so therefore, we have to pay attention to that. We need to look at how are we best taking care of our patients operationally with the right technology, with the right sets of clinicians, and still be able to pay the electric bill monthly. So I end when we're talking about change management. Yes, there are folks that come with us some great ideas, and I'm just going to paraphrase with, we need to make that widget blue, and here is why. We also then need to look at what's the greater good and how's that going to serve. And Dr. Anderson had mentioned that, so I will not repeat that. But so thanks for going to where I often go to, because I'm a nurse at heart and want to make sure that we care for the patient. We also recognize we all work in a checkbook.
I think Dr. Norquist had an excellent point about even on somebody saying it's for patient safety and waving that flag, but asking how and why.
Yep.
Sometimes I think we don't do that. It's, oh, patient safety. Well, gotta jump on that, you know, so really great points. We don't see any, let me just make sure. Nope, no additional questions in our Q&A. So would like to give everybody the chance in our 5 minutes left to, if you have anything else to say. I think this has been an excellent discussion, and I want to thank each and every one of you for participating. I'm interesting format, and I really liked it, actually. I think we really got some great content out there. So
And Terry, do we have a feedback mechanism for like potential future firesides and questions? I think that would be great if there's a feedback
think
mechanism.
That's a great idea.
send out some, we can definitely do that and send out to get some feedback on what you thought about today, and then some other additional topics. We would love to do that. So I will definitely take care of that. So yes. Any
Yeah.
other questions, comments? I want to thank, both again, the Arizona HIMSS chapter and the Arizona Nursing Informatics Association for putting this on, and thank all of you for attending. And please, again, give us some feedback. We really enjoyed doing this.
Absolutely. Thank you, doctors, and good
Thank you,
seeing
guys.
everyone.
Thank you. Thank you all.
Right.
Take
All
care.
right,
Thank
have a great day.
so
Bye,
much.
guys.
Okay,
Thanks.
thanks.